And we're going to go ahead and get started. We'd like to greatly thank Dr. Sarah Spencer for joining us today on this topic, a very important one on benzodiazepine tapers. And so a little bit about Dr. Sarah Spencer is she's board certified in family medicine and addiction medicine, has been providing treatment for opiate use disorder in rural Alaska for over a decade. She's currently an employer of the Nilhachek Traditional Council and provides family medicine and addiction treatment services at their tribal clinic, including telemedicine to remote Native villages. She's the volunteer medical director of Alaska's first rural syringe access program in Honar, and is the co-author of the state's medication for addiction treatment guide, and provides addiction medicine consultation for nonprofits, including the Alaska Native Tribal Health Consortium and its Opiate Response Network. So busy lady, and I'm so glad that she was able to fit us in, and I greatly appreciate it. Now, just some housekeeping. As you know, our CME system, please text the following code, 804-798, to the CME phone number, which is 1-800, or not 1-800, 1-866-327-3062. Steve has dropped that information in the chat, and we'll be providing that throughout the call. So I will turn it over to our fabulous speaker.
All right, thanks. Thanks for inviting me. I'm going to try to share my screen here to get the slides up. All right, is everyone able to see those slides now? Okay.
Yep, you're good.
Okay. So I don't have any financial disclosures. For our objectives today, we're going to take a look at benzodiazepines and some of the potential risks with tapering them, and really kind of focusing on a variety of different strategies that you might use to approach benzodiazepine tapers. So benzos, of course, when they were introduced, were all the rage, and prescribing they felt to be very, very safe medication compared to options that were available previously. But what we found over time, of course, is that that they're not the best treatment for anxiety. And the one of the main differences in the benzodiazepines is how what their half-life is. And so we're going to be focusing on mostly on looking a little bit more at diazepam as an option for a tapering strategy when people are on the more short-acting benzodiazepines like alprazolam that have a lot of ups and downs and can be particularly challenging when we are tapering them. So a lot of benzodiazepine prescribing is really off-label. Benzos really are not indicated for long-term treatment of anxiety, and they're often used for things that really, like depression, muscle spasms. They don't have a lot of great evidence for a lot of the reasons that they are being prescribed for. And similar to kind of what we see with opioids, unfortunately, the withdrawal symptoms from benzodiazepines replicate the symptoms for which we're using to treat them. That always makes a medication more difficult when we're dealing with medications that cause a physiological dependence, and then the withdrawal symptoms mimic the symptoms we're trying to treat. So when people try to stop, they're taking their medication, the benzodiazepine, for anxiety, for muscle spasms, for sleep problems, and when they try to stop taking these, the withdrawal symptoms mimic those symptoms and make them feel worse. So that presents a particular challenge to tapering and discontinuing these medications. There is, for long-term use of benzodiazepines, there have been a number of reports that have come out kind of linking things to issues like cognitive changes and dementia, and the evidence is not particularly strong for that, but there's some indication of that in some studies. But particularly the benzos work similarly, like alcohol, also acting on the GABA receptors. And so when those receptors are down regulated over time, and then the benzodiazepine is taken away suddenly, then we're having less inhibition of the excitatory neurotransmitters, and we're getting a pro-excitatory state. And there really is no specific cutoff, like, okay, you're only going to experience withdrawal if you're at this dose, or if you've been taking it for this period of time. There isn't really a known set duration or dose that we know will definitely result in withdrawal when it's stopped. So the elderly in particular are going to be most at risk for side effects or morbidity related to benzodiazepine use, especially with worsening cognition, risk of falls, and other issues like that. So the risk of adverse effects is going to increase in the older patients. And in general, over time, benzodiazepines might really make the underlying anxiety worse. And there's certainly some studies that demonstrate that the outcomes can be worse for anxiety symptoms, patients that have PTSD. So not a great long-term solution for anxiety. And over time, they don't appear to improve quality of life over time. And in fact, many people who take the medications over time still report a lot of ongoing symptoms, and sometimes symptoms that are getting worse when they're taking the long-term benzodiazepines. And patients don't always have a good understanding when they start taking the benzodiazepines, that the long-term use of them can result in problems, and they aren't necessarily given a good informed consent about how difficult it may be to stop taking those medications when if they are continued for the long term. So a good informed consent is really important when patients are, when you're starting a patient on benzodiazepines, or you're, in my case, most of the time, in my case, I'm inheriting patients who come into me on chronic benzodiazepines, and they really haven't had that conversation yet of really sit down and looking at the risks and benefits, long-term risks, issues related to withdrawal and dependence of them. So I make sure to, when I get my new patients in, to just sit down and go over these, even if they've been on these medication for years. And to this, if you're looking for a very, very thorough informed consent about risks associated with benzodiazepines, there's a link here that has lots and lots and lots of references, which are quite interesting if you want to look up a little bit more about some of the risks, references for some of the risks of benzodiazepines to share with your patients. So this can be a good place to start and edit it to your needs. So when we think of who should we think about tapering benzodiazepines for? For patients, we want to prioritize this. Folks who are on multiple risky substances, especially the combination of benzodiazepines with opioids, is going to increase the risks with that. Folks who have a history of substance use or dependence are going to have more associated possible risks with benzodiazepines. Of course, if people are already experiencing cognitive dysfunction, those can be making that worse. In the older patients who are at higher risk of side effects, and very young patients as well. And the VA notes this specifically, that that benzos in those patients can, make things worse over time, and they're going to do, much better evidence over time for long-term treatment with more evidence-based treatments like SSRIs and other psychotherapies. So it's critically important, though, to get the patient on board with this. This is a long-term project. It can be really taxing both for the patient and the provider. And we need to work on doing some motivational interviewing and really developing that therapeutic relationship with the person to gain their sense of trust to start this difficult process with them. And so talking with them about some of the benefits to reducing or discontinuing their benzodiazepine in the long term can help to get them on board with participating in this, and really increasing their chance of success. You really need to get patients on board with that. So this is I think a nice resource that provides some education for patients and some guidelines to, talking with your patients about this. And it's something that can take a number of visits to develop a plan with the patient, really getting them on board and making sure that everyone is really committed, and the patient feels empowered that they are playing an active role in this process. And it's just more of the same. It's important to really realize that, trying to push patients when they're not ready, trying to rush the process, trying to do it quickly even when the patient is uncomfortable. In many cases, especially patients who have been on these medications and have been stable for many years, you're likely to cause harm, or the patient to abandon the process if you're pushing them to go too quickly. So it's not a race. Want to try to keep things simple and set realistic expectations, and go slow, and be willing to pause the process and not push patients faster than they're ready to advance. When benzodiazepine withdrawal goes too quickly, it can be just really, really miserable for patients. The symptoms can be just really, really relentless, and similar to opioid withdrawal, except lasting much longer. Can just be very difficult for patients to handle, and of course, if it's done too rapidly, patients can end up with really significant side effects from the taper. And I think it's really important for us as providers to have a safe, non-judgmental atmosphere and conversations with patients, that we are not treating them poorly or stigmatizing them because they're taking long-term benzodiazepines. And being flexible with patients to find out kind of what has worked for them in the past, what approaches they would like to try, and offering flexible options for tapering can help to get people on board. So with benzodiazepine withdrawal, the things we're going to hear a lot from patients is anxiety, insomnia, muscle spasms. Of course, with sudden discontinuation, the fear, of course, is experiencing seizures. And this can go on for a long time. The post-acute withdrawal syndrome can last for months after the medications are discontinued. So the going slow and really preparing people that that the symptoms that they're experiencing after discontinuation can persist for a long time, being there to support them through those symptoms, and setting those kind of realistic expectations. The acute withdrawal monitoring withdrawal symptoms, if someone's experiencing acute withdrawal, is scored very similar like we would with alcohol. There's a C1B that's particular to benzodiazepines, and this is scoring that is mainly meant for medical personnel to score, but is an objective way to score the severity of the physical withdrawal symptoms. So for choosing who would be a good candidate for outpatient withdrawal management, the patient has to be on board. They have to be motivated. They have to be able to understand and follow the directions. Ideally that they have some support. If they live alone and they don't have any transportation and they're having an acute reaction, that's going to be might be a difficult situation for them. Now, the tricky part comes in when patients, if they are experiencing a benzodiazepine use disorder and they are not able to take their benzodiazepine as prescribed and they're using non-prescribed benzodiazepines, that's going to be a particular challenge to get the person to follow the directions of the taper. By definition, if someone has a use disorder, they're not able to control the use of that substance. So in my situation, I see lots of patients with benzodiazepine use disorders, and when it seems to be pretty mild, I'll almost always give people a shot of doing an outpatient taper with very short prescriptions and very close monitoring. But it's going to be much more challenged. That you're going to be much more successful when you have patients who either have very mild use disorder or otherwise able to take the medication as prescribed. And ideally, someone who is relatively mentally stable, doesn't have severe other medical comorbidities that might complicate the picture and make it difficult to interpret the person's symptoms. When we're doing tapers, especially in my situation, most of my patients have a comorbid substance use disorder. And it's not necessarily with benzodiazepines, but I'm going to be monitoring urine drug screens as I follow up with them with their benzodiazepine tapers, and will frequently be sending out for confirmatory benzodiazepine testing. It's important to remember that certain medications like clonazepam often does not show up positive on a rapid urine drug screen. So it may look like the patient's not taking it when indeed they are. And you can't tell which benzo they're taking. It's just positive or negative on your rapid screen. So especially if you have some concern of the use of other brands of non-prescribed benzodiazepines, that confirmatory testing can be really, really helpful. And it's when you're ordering the confirmatory testing, it can be a little confusing looking at all the metabolites. For example, if you're prescribing diazepam, you're typically going to see all four of the diazepam, nordiazepam, temazepam, and oxazepam at different levels all together in the urine from the prescribed diazepam. So it can be helpful if the metabolites you're seeing are confusing and you're not sure if they're right. It can be really helpful to call the number on the lab and speak with the medical review officer to help you interpret the metabolism of the benzodiazepines that you're writing, to make sure that the patient is taking the ones you're prescribing and not taking other non-prescribed benzodiazepines along with it. So the basics of the outpatient taper is, first of all, if a patient is on short-acting benzodiazepines like alprazolam or lorazepam, we are first going to try to convert to a long-acting benzodiazepine, either clonazepam or diazepam, but I would encourage the use of diazepam, which we'll talk more about later, to allow for some more flexibility in the taper. And if you look at recommendations for tapers, they're all over the place. Like, oh, go down 10 to 25% every week and be done in a month or two, versus 5% a month and it lasts for 2 years. So there's no one right answer. It depends on the patient's particular situation. Are they in a situation where they're in a rush and they need to taper rapidly, or are they able to follow the directions and stick with the plan and prolong that over a longer period of time to make it less uncomfortable. The there are equivalency charts, of course, with benzodiazepines, just as there are for opioids. In generally, when similar kind of recommendations to when you're first making a switch over with opioids, when you can make that conversion over and you make that calculation, it's probably safer to kind of reduce the calculated dose by about 25% to adjust for some metabolic variance between the different brands, and then to follow up within the next couple of days to ensure that calculation appears to be correct, that a patient is not experiencing withdrawal, that they're not overly sedated when switching to a new brand, switching from alprazolam to diazepam, for example, and allow patients a couple of weeks, ideally, to get used to that, stabilize at that dose on the new brand of benzodiazepine that you have them on. And then after they stabilize, then start the taper process. And generally, the first reduction can be significantly bigger than further reductions. So you might be able to get away, with the first reduction of 10%, 20 or 25%. But as you go on and the doses get lower, we're going to make smaller and smaller reductions. And you may want to consider a more rapid taper when patients have been on these medications for a shorter period of time. But certainly when patients have been on benzodiazepines for more than a year, in most cases to have good success rate, keep patients on board and keep them comfortable, we're going to be looking at 6 to 18 months taper period to keep the process as comfortable as possible for patients. And and just to remember that even if you're reducing by 10% every time, that as you get to lower doses, that is going to be a smaller and smaller amount. So initially, like on 40 milligrams of diazepam, you could reduce it by 4 to 5 milligrams with that first reduction. But then when you get down to below 10 milligrams, then a 10% reduction will be 1 milligram. So the amount that is going to be reduced is going to get smaller as we get to lower doses. Now, there are certain circumstances where we just can't, the long tapers are not possible. And so this may be in a circumstance where a patient does have a benzodiazepine use disorder and they're really not able to follow those directions, or they may have other medical conditions that really they're kind of in more immediate danger from the effects of the benzodiazepines. They may be going into a situation where they're not allowed to take the benzodiazepines, maybe certain residential treatment programs that don't allow that. And So if a taper needs to be done rapidly, there are a few different approaches with neuroleptic medications that can help to reduce risks of dangerous issues like seizures. It's not going to be comfortable no matter what. These rapid tapers are going to be uncomfortable for patients. They're going to have a lot of anxiety, and they're going to have post-acute withdrawal symptom that's going to persist for a while beyond that. But from a safety perspective, just reducing the risk of seizures, there's a couple different uh, protocols that have been reported to consider use in these patients. So this one here is with pre-medicating with either valproate or carbamazepine for a couple of weeks prior to the taper, and then continuing that medication for a month after the discontinuation. And this is looking at a really rapid taper where the medications are discontinued and tapered in less than a week. This is another paper that's looking at, this was in a patient who was inpatient, but in administering carbamazepine as an adjunctive to reduce the symptoms associated with the rapid tapering of diazepam in this case. And generally for the inpatients as well, phenobarbital has also been studied looking at rapid tapers and has seems to have good results and fairly well tolerated. This particular paper was looking at patients who were also on medication for opioid use disorder who needed to have a rapid taper of their benzodiazepines. And most patients tolerated it well. Without many complications of this. So those are options for patients, and most of them were able to discharge without being readmitting. Adjunctive medications, there are lots of different things that you can try to help with some of the symptoms that people are experiencing during their taper. I think hydroxyzine is probably one that we see used a lot in patients as a kind of a PRN to reduce their anxiety during their taper when they have an anxiety disorder in general. Trazodone can be somewhat helpful in sleep in these patients. The gabapentinoids can be somewhat helpful during, again, continued during and then after the taper. I use a fair amount of buspirone in my patients. Again, to help with the symptoms, but also to help with the treatment of anxiety. Melatonin possibly for sleep. And we're going to talk a little bit more here about flumazenil, which is pretty interesting. So we think of flumazenil as something we never want to give someone who is physically dependent on benzodiazepines. But interestingly, there's been a number of articles that have looked at these very low dose, slow infusions of flumazenil that are given during rapid inpatient benzodiazepine withdrawals. And it actually, there's been a number of studies that show that they actually improve symptoms, and patients have better outcomes with their rapid withdrawals with this very low dose flumazenil infusion, which is pretty interesting. This is, I think, a great resource when you get those patients and you're trying the bread and butter taper that you normally would do for other patients, and people are just struggling. They're not trying to cut out that quarter of a pill or a half a pill. They're having pretty significant symptoms. It feels like it's too fast for them. So if you want to look at some alternative strategies for tapering. This is a great resource. This is put together, the Benzodiazepine Information Coalition is put together by a group of physicians, and it compiles a bunch of great resources to give you lots and lots of different ideas than your typical run-of-the-mill benzodiazepine taper. And specifically, when you're considering which benzodiazepine to use, I think diazepam is really nice. First of all, it does, have one of the longest half-life. So we're going to have more steady levels and not so much ups and downs in between, the interdose withdrawal that you can get with short-acting benzodiazepines. You can dose it more than once a day, but it doesn't have to be dosed, multiple times a day, like a patient might be taking their alprazolam. And the nicest thing about diazepam, because it's less potent, you have a very broad range of dosing formulations, which is really nice when you get down to the lower doses. So if we think of compared to clonazepam, the typical tablet, if we're not talking about the dissolving tablets, the typical tablet, smallest tablet's going to be available is going to be 0.5 milligrams, which is the same as about 10 milligrams of diazepam. And then when you're trying to reduce the dose farther from there, trying to cut these tiny little tablets into even smaller pills can be a real struggle, versus the diazepam coming in really small doses, like 2 milligrams. You can really have much more flexibility with getting a more precise and more customizable dose on the smaller, on the lower dose range of things. So I think diazepam gives you much more flexibility, especially when you're getting towards the end of the taper, to allow things to actually go as slow as you need them to. Dry tapers is your run-of-the-mill basic taper. You're using a pill and you're cutting it. So the most common would be cutting and holding, meaning that you are taking a pill. Let's say we're going to cut a quarter of the pill out, and then we're going to stay at that dose for 2 weeks or for a month before we then reduce further. It's really important to allow the patient time for those, if they do experience withdrawal symptoms when the dose is reduced, allow them time to stabilize at that dose before you progress with further reductions. But you can also do micro tapering with pills, which again, this is for patients that really struggle with reducing the dose. If they're highly motivated and they want to do something a little bit more complicated, then they can actually, rather than cutting a whole half a pill or a quarter of a pill off, shave really small amounts off. And if a patient is able to obtain a good scale that's meant to weigh really small weights, then they actually can potentially weigh the amount of tablet that they're taking to get the precise dose. But it's harder to do with a pill than it is with a liquid. So a liquid allows you even more flexibility to get a really precise, very small changes in the dose. And so some of these, in this resource here, some of these tapers, look at reducing the dose by really tiny amounts, like 1/10 of a milligram, and then doing that on a more frequent basis every couple of days, to have a slow, very gradual reduction in dose, rather than these more abrupt step-offs you'll experience when you're cutting the pills. So this can be done with ideally, a manufactured solution is nice, because we know that the solution is stable, and make sure the patient has a syringe that's appropriate to measure the correct amount that they're going to be measuring. You can also, if you're not able to get a liquid solution from the pharmacy or get one compounded, patients can crush tablets and mix them with water or milk. The issue is that they're generally not actually water soluble, so need to be shaken very well before drawing up the appropriate amount of the medication. This is a resource called the Ashton Manual, which is written by Professor Ashton and has lots of really great resources for examples of ways that you can taper benzodiazepines differently. And she gives many examples of slow withdrawal schedules from a variety of different medications. And she gives examples of, switching over kind of rather than switching all together, like from alprazolam to diazepam, starting with substitution, where you kind of substitute one pill at a time rather than switching all over all at once. And she also looks at other Z drugs and that sort of thing, not just the classic benzodiazepines. So this is nice in that it gives an actual written out schedule and many different kinds of approaches, so that you could find something that might be a better fit for your patient than just the bread and butter classic tapers. Now, to complicate this, we're seeing more and more of these illicitly manufactured novel benzodiazepines. And in my area, the one that I'm seeing is bromazolam, and patients are ordering this online off the dark web. And this really complicates issues. Many times these are patients who also have a substance use disorder and may have a benzodiazepine use disorder, and trying to figure out the equivalency to switch them over to diazepam, for example, can be a huge challenge, because there's very little data out there on a lot of these novel benzodiazepines on getting an accurate equivalency table to figure out how much do they really need to stabilize them on a commercially available benzodiazepine. This also really complicates as well the monitoring of this. If the patient has a use disorder and the main drug that they're using is one that your lab cannot test for, doesn't show up on the confirmatory testing, then it's really difficult to monitor if the patient is still continuing to use that or not. So our confirmatory lab company we're using right now is Millennium, and I think about in the last year they did add on a panel of illicit novel benzodiazepines, which is somewhat helpful, but unfortunately bromazolam, which is what my patients are using, is not on that list of illicit benzodiazepines. I just had a patient this last couple of weeks that came to me for this, and found out that he was still continuing to use the bromazolam a couple weeks into the taper and hadn't stopped. But we would have been able to find that out sooner if we were able to get the information, off of the urine. So talk with your lab companies. When I talked with Millennium, they said that they are going to be adding bromazolam on after the first of the year, which is great news for us and our patients. But specifically when we're seeing patients who are taking benzodiazepines with opioids. We know that is a particular risk, especially when you have a patient with an opioid use disorder, and they're always going to be at risk for, especially early in treatment, at risk for returning to use with opioids. We really worry about that, the risk of overdose when combining opioids with benzodiazepines. Benzodiazepines by themselves, without any other CNS depressants, are relatively safe in terms of overdose risk. We don't see many overdoses with benzodiazepines alone, but the vast majority of overdoses with benzodiazepines currently are showing the involvement of an opioid with them. So when you get patients coming into your practice, which I often do, who are either co-prescribed benzodiazepines or opioids, or just taking the two together, maybe they're prescribed benzodiazepines but using illicit opioids, the opioid is the drug that's most likely to cause the fatal overdose. If we can reduce that risk, then we're not in such a rush to address the tapering of the benzodiazepine. We can take our time with that. And so I would strongly consider, if we have a patient who has opioid use disorder, clearly we're going to be, switching them to something like buprenorphine to manage that. But I would strongly consider switching other patients who are taking prescribed full opioid agonists for their chronic pain, let's say to buprenorphine, to reduce that overall overdose risk. And the CDC and the VA now in their new recommendations both recommend switching patients to buprenorphine from their full opioid agonists to reduce risk. And in general, the literature supports that it's at least as effective, if not more effective, for chronic pain, probably less opioid-induced hyperalgesia, less side effects than full opioid agonists. So most patients that make the switch end up being actually very happy with the switch from the full agonist to the buprenorphine. And then you're going to dramatically reduce that risk of respiratory depression when the patient is also on the benzodiazepine, and it gives you much more flexibility and time when you have the patients safely stabilized, to really take your time with that benzodiazepine taper and not feel that you have to rush it. And CBT is very effective in helping to reduce symptoms and increase success in a benzodiazepine taper. And so many patients who come to me who have, report, really severe generalized anxiety, PTSD disorders, really have never tried a good therapeutic trial of CBT. CBT for insomnia is particularly effective in treating insomnia. And, just talking with patients about the fact that this can really help to make the whole process much more comfortable for them and more successful for them might help to get them on board with participating in CBT. And sleep can be a big struggle during the taper and for a long time after the taper. And just as a reminder, most of our medications that we typically prescribe to help with sleep are all off-label. Things like trazodone, doxepin, TCAs, mirtazapine. None of these are labeled as an indication for insomnia, and yet we use them. And they medications for insomnia have very, very little evidence for their efficacy, but I think they can be a source of comfort for some patients, especially when they really associate that dose of benzodiazepine with their sleep and with insomnia. The VA does make a free CBTI app. A lot of the apps for insomnia and CBT are paid apps. So if you have a patient who's not able to afford one of the paid apps like Calm or that kind of thing that has guided meditations and things, the VA one might be a place to consider starting for a patient to get a little glimpse of what the CBTI might be. And if you're looking for a good book, or if you have a patient who might be willing to learn a little bit more about sleep, this is an excellent one. This really, and the audiobook is it's a recent, I think this book came out just 2 years ago. Dr. Winter, he's a sleep neurologist. Really completely changed the way that I think about sleep. And the few patients that I've gotten to read this book, stop taking their sleep medication. So it really reframes sleep in insomnia as an anxiety disorder. It's not, there are clearly sleep disorders like sleep apnea and restless legs and shift sleep disorder, but insomnia for most patients is an anxiety disorder, and it's the anxiety about their quality of sleep. It's not that they're not sleeping. And so this book was just very insightful, very easy to listen to, really easy. I really enjoyed just listening to the audiobook in the car, and I got so much out of it as far as how to talk with patients differently about insomnia and how to just look at it from a very different perspective than I used to. And many patients, it always surprises me how many patients come to me on benzodiazepines who really have not had a good therapeutic trial of, really evidence-based medications to treat their underlying anxiety. And so this may be a time when they are more open to the idea of trying some of those medications again, and trying a good therapeutic trial of an SSRI or another evidence-based medication to treat their anxiety. And so getting patients on board with, even though you've tried something in the past, you're in a different time in your life right now, and with the change in your medications, you may find that this helps in a way that maybe it didn't help before. And I think especially with patients who are taking short-acting benzodiazepines, they almost, they're looking for a PRN. They want a PRN. They want something to take to help them to feel better when they need it. And of course, your typical medications like SSRIs are not going to offer that. So I do often offer patients PRN medications during this process, like hydroxyzine, clonidine, or propranolol, that can help to treat give some quick relief and treat some of the physiological symptoms that can kind of mimic anxiety, to help them deal with some of the discomforts of the taper. Some resources to look into: the VA has a nice, relatively brief, to the point toolkit for tapering benzodiazepines that I think is worth looking into. And this is the Benzodiazepine Information Coalition that I mentioned, that is the content is created and managed by addiction medicine physicians, and has links to lots of different, has the link, a free link to the Ashton manual that has the dozens and dozens of different tapering strategies, talks a little bit more about the strategies like the liquid taper, and has the link to that the benzodiazepine treatment consent that kind of talks about the risks that you can talk about with patients. So I highly suggest connecting with that resource. So I'm going to stop there and see if we have some questions, or if there's some other things that people want to talk about in terms of this subject.
I did drop a few of your links that you were talking about as you were going, the VA CBTI app. Not only does it have, the VA have a great CBTI or CBT for insomnia app, but they have a whole host of apps that people can use, and they're free and they're very evidence-based. So there is that in the chat, as well as the link to your sleep solutions, Why You Are Broken, and then the Ashton manual. Definitely a resource that I share with my fellows here as a great tool and resource. So it's always helpful. We do have a request for the slides, but I don't see any
Yes.
kind of questions in the chat.
Yeah, you can certainly feel free to share the slides.
Okay. I will put my email in.
All right. Well, again, I'd like to thank you for coming and sharing your, depth of knowledge on this topic. I feel like it's something that that we're all trying to get a grasp on now that we are, we have tackled opiates. Now we got to be really thinking about benzodiazepines. We probably should have been thinking about both of them the whole time. But thank you so much for all this information and your wonderful presentation.
Thank you, Dr. Spencer.
Thank you. Thanks for inviting me. Hope you guys all have a great day.
Thank you, you too.
Okay, bye-bye.